Before we start today's episode, I would like to quickly read you our podcast disclaimer. The content in this podcast is for general reference and educational purposes only. It is not meant to be complete or exhaustive or to be applicable to any specific individual's medical condition. No information provided in this podcast constitutes medical advice and is not an attempt to practice medicine or to provide specific medical advice, diagnosis, or treatment. This podcast does not create a physician-patient relationship and is not a substitute for professional medical advice, diagnosis, or treatment. Please do not rely on this podcast for emergency medical treatment. Remember that everyone is different, so make sure you consult your own healthcare professional before seeking any new treatment and before you alter, suspend, or initiate a new change in your routine. Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets,
two internal medicine doctors who spent years practicing traditional primary care. Over time, we realized something was missing from modern healthcare. A real understanding of how everyday lifestyle choices impact overall health.
We'll help you cut through the noise of the countless health influencers and their conflicting opinions, because no matter who you follow, the basics of lifestyle medicine are at the heart of it all.
Welcome back to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets. This week is week 2 of our 3-part series on sleep, and we are so excited. Last week, we talked about the many ways sleep impacts our health, how your daily habits might be helping or hurting to get that quality rest that we all desire. So now that we've talked about why we need to sleep, we're going to focus today on how to sleep. We want to talk about our natural circadian rhythms, sleep environment, what to do if you're having trouble sleeping, and the differences between falling asleep, staying asleep, because we may need to look at those differently when we talk about different advice. So Kitty and I have loved learning about sleep, but we're still not a sleep expert. So we really wanted to bring on a guest that does this day in and day out.
Right, because you may have heard our episode last week and thought, yes, I understand sleep is important and I really want to get more sleep, but I can't sleep. And so we're really hoping that if that's you listening out there, that we can help you today. We have a guest with us, Dr. Ryan Wetzler. And Dr. Wetzler is double boarded in sleep and clinical health psychology. And he has developed his own clinic in Louisville, Kentucky. And it's a comprehensive cognitive behavioral treatment program for insomnia. It's called the Sleep Health Center. And he's been able to help many people over the years learn how to sleep. And I actually first heard about Dr. Wetzler through someone I knew personally, and I didn't know that she had struggled with sleep for many years. But she ended up seeing Dr. Wetzler going through his, and I'm going to shorten our cognitive behavioral therapy for insomnia to CBT-I for the rest of the show, went through his program for CBT-I and actually started sleeping for the first time in many years. And she said, Kitty, you would not believe how this has changed my life. And after hearing her experience, I ended up sending some patients to him over the next few years and really seeing what a difference it can make for people. So, Dr. Wetzler, thank you so much for joining us today.
It's my pleasure to be here, and congratulations on this podcast. It's incredible to get this information out there for folks.
Can you give us a little introduction into you, where are you from, and what has taken you into this world of sleep?
I started out pre-med biology at St. Louis University, and in my second year, I was introduced to a new field of study that just absolutely captivated me. And the area of study was called psychoneuroimmunology. And so this field was looking at how mind factors, our thoughts, our emotions, impact our underlying neurology, and then the trickle-down effect that this has into virtually every bodily system, specifically our immune system, our endocrine system, etc. And so at that point, I also learned about a new field called health psychology that was being born out of this information. It was developing this understanding that a vast majority of chronic health problems that we're dealing with are either the consequence of stress and or our behavior. And so the thought at that point was the future of healthcare has to change. That it has to change. And
Sarah's
so the
laughing.
Thought, right? Yeah, the thought at that point was for sure this was going to become how we treat people. And the thought as well was that in the near future, there was going to be a health psychologist working side by side with primary care physicians to more optimally assist folks in managing these conditions related to stress and or behavior. So I switched my major to psychology. While I was at Spalding studying clinical health psychology, my professor and mentor, Dr. Andy Meyer, came into class one day and he said, "Hey, I just had this discussion with the sleep physician that really needed some help in managing all these folks that kept coming in complaining of insomnia spectrum disorders. And was there anyone in this class who might be interested in coming over and developing a treatment program to help these folks?" So I was the person who raised my hand. That then led to spending time with those who were experiencing this condition and ultimately developed my first insomnia treatment program back at that point, and that became my dissertation. So then the next step of training is residency, and my residency took me to a VA medical center. And as you might guess, there's a lot of insomnia at the VA medical center. And before I knew it, I was getting calls from all these different areas of the hospital asking me to come and do talks on this. And I guess finally it dawned on me, hey, this could be important. Maybe I should think about making this a full-time gig. I ended up back in Louisville at a practice called Sleep Medicine Specialist. They wanted me to continue to develop the insomnia treatment program, but they also were interested in developing programming to assist folks with all the different sleep problems they really didn't have the time or interest in addressing, which included, of course, insomnia and circadian rhythm sleep disorders and parasomnias, both REM and non-REM, as well as assisting folks in hypersomnolence disorders or sleepy all the time, we don't know why, as well as to assist folks in tolerating positive airway pressure for treating sleep apnea. And so then I spent the next 14 years developing these sorts of programs. I desperately was trying to make it work within the system as it is. Unfortunately, profitability is an important thing, and unfortunately, mental health reimbursement is such that in order to try to make this work, I was scheduling 15 people a day. I was just trying desperately to see enough people to be able to do this sort of work, and ultimately realized that unfortunately it doesn't look like I can do this. I was killing myself trying to make this work. Then, about 7 years ago, I decided, you know what, I'm just another widget factory here, and that didn't sit well with me. There's so much that I was missing, and again, I didn't realize just how much I was missing until I started my current practice, where now I have the ability to spend an hour with every patient. And so, I guess that's what brought me to this point. So now we've had Sleep Health Center open for the last 7 years. Things are going great. It's incredibly rewarding work because it's amazing how quickly people can get better.
And just seeing how improving your sleep impacts every aspect of your life and your health, and just how much more someone can enjoy life when they are actually sleeping. To get us started, can you just go through with us a little bit about what is a circadian rhythm?
Circadian's very specific, and I think it might be best to take a broader look back at the sleep system and how it works and why it works like that. So our sleep system was really designed to function optimally in the world of thousands of years ago. Quite often people will come to me and they'll be like, okay, I just want you to tell me one thing. Tell me the one thing that I can do, right, to make my sleep better. And often what I will come back with is I'll say these systems were designed to work in this world of yesteryear. And so if you want one thing you can do to improve your sleep, it is to try to mimic what life would have looked like then. So if we think about this, what would life have been like a few thousand years ago? What would the average human have been doing all day?
Physical labor.
Right, yes.
Yeah.
Right?
Up with the sun, down with the sun.
Yes, you'd get up when the sun came up. And then you'd be out walking, looking for food all day long. And then in the evening when the sun went down and you could no longer be out there doing this, the sun would go down, you'd come back, you'd lay your head on a rock and fall asleep. Whenever we think about sleep, we need to understand the origin. What kind of world? And so, yes, we need to do everything we can to do our best to try to mimic that. Now, obviously, the modern world gets in the way in just about every way conceivable.
Yeah, there's nothing in the modern world that looks like that. So you have to work hard to recreate it because there's very few people that experience that.
So for someone that is struggling with that and let's say is up before the sun comes up and is working or active, going places and doing things with their kids in the evening, and they come home, they need to be able to go to bed. What's the best way that someone can try to turn that busy lifestyle and mimic that lifestyle of old?
Yeah, so whenever I evaluate folks, really what I'm trying to look at is there are 4 primary systems that are involved in sleep. We have the circadian timing system, which regulates the timing of sleep, and we can talk in more detail about that here in a bit. We have the homeostatic sleep drive system, that accumulation of adenosine through the day as we are out moving around. Cellular metabolism is building this. It accumulates like hunger. And that circadian system, that homeostatic sleep drive system, then interact with our sympathetic response or our fight-flight response. And then that interacts with learning and experience. And so when somebody comes in and I'm evaluating them, I'm looking at where is the problem? Is this a circadian issue? Is this a sleep drive issue? Is this an anxiety issue? Have they learned over time that they just can't? And so we're looking at these 4 quadrants, trying to determine, okay, what is the actual cause of this specific challenge with sleep that this person is having?
No one has ever explained it that way to me, and that just makes so much sense.
It does, yeah.
As part of our evaluation, we give the morningness, eveningness questionnaire, which it's not an exact instrument, but it at least gives us a starting point to try to determine what is this particular individual's chronotype. As you're aware, some people are morning people, some people are night people. We need to know up front what is this person's tendency on that before we're going to be able to intervene successfully. And so whenever I talk with folks about this, it's all about education. It's here, let me help you understand how this works, and not just in general, but how your specific circadian rhythm works. And so if we're talking more generally, more broadly, what we're really talking about is the functioning of a little bundle of neurons in the human brain called the suprachiasmatic nucleus. How this area of the brain works is it's really designed to serve as our built-in sleep clock. And the job of that sleep clock is to keep our bodies oriented to the natural light-dark cycle. So this area of the brain instructs the body as to when it is day and when it is night, when we should be asleep, when we should be awake. How this area of the brain facilitates that understanding is through exposure to environmental cues. Those cues are otherwise known by a German word, Zeitgeber, or time giver. So the time givers to that clock include most powerfully our initial exposure to bright light, particularly sunlight. Second is physical activity. Third is socializing. And fourth are meal times. Now, we can throw ambient temperature in there as well as a relatively weak Zeitgeber, but if we put it together, every day when we get out of bed, we get up, walk in the bathroom, we flip on that light, and what are we going to experience? The squinties, right? That eye sensitivity to the first bright light of the day. Then as we get up, we start moving. What's happening is all of those Zeitgebers, those cues, are communicating that it is daytime to the suprachiasmatic nucleus, which is then transmitted back to the pineal gland, which suppresses melatonin production for the day. And then we're in daytime mode. And we'll be inclined to remain in daytime mode as long as we continue to be up and moving around and well at circumstances, talking to people and eating. And then in the evening, when the sun goes down, when activity starts to slow down, we're chilling out on the couch, watching some TV, doing some reading, then ultimately the brain will conclude, aha, it must be nighttime, which is when a signal is resent back to that pineal gland, which turns our melatonin factory back on. And then 2 to 3 hours after melatonin production is reinitiated, we'll have accumulated enough of that hormone in our system to start feeling sleepy enough to initiate sleep. And then this process repeats.
So I'm a morning person. You've probably heard me say that at some point on the show before. And I feel very lucky that I'm a morning person because I think our society is scheduled and geared toward morning people. And so it is easier for me to get up and get moving in the morning, see light, and be winding down at night. But for those people whose, what do we call it, their chronicity is...
Yeah, their chronotype.
Their
is maybe
chronotype,
not morning.
right? Let's say they're an afternoon or evening person, but they're stuck in this morning person world where they need to work morning people hours and go to sleep early enough to get up and start the next day. What's the best thing they can do to try to help adapt?
The beauty of all of these systems is they are malleable. If you go over a year, there's differences in when the sun comes up and goes down. There's differences in how much light there is and how much dark. And so I think we need to appreciate that there's reason for that. There's reason for that adaptivity. But I think it's also important to understand, what does it mean to be a morning person biologically? What it really means is coming equipped with a sleep clock that runs less than the natural 24-hour light-dark cycle. Whereas folks who are more evening types will have sleep clocks that run longer than that natural 24-hour light-dark cycle. So, interestingly, the average human sleep clock does not run at exactly 24 hours. It actually runs closer to 24.2 hours. And whenever we think about these chronotypes, the intermediate circadian type then would have a clock that runs at roughly 24.2 hours. If you're a morning person, it runs, again, a standard deviation or two less than 24 hours. And again, those who are evening types will have clocks that run a standard deviation or two longer than that 24.2 hours. So if somebody has a sleep clock running longer than 24 hours, that clock is always going to want to drift west. Meaning that if we put that person in a cave, taking away any cue as to what time of day it is, their sleep schedule would drift 12 minutes later every day until they ultimately went all around the clock. So in order to prevent that delay, it would mean that person, unfortunately, would need to commit to getting out of bed every day about the same time no matter what. Because if they allow, again, themselves to sleep in, that circadian clock will drift. If we think about this mathematically, if we put those two, that circadian timing system with the sleep drive system, we can translate it into what I like to call the 16-hour rule. Now, obviously, there's variabilities in how much sleep people need, but if we consider 8 hours being the average, what that really means is it's unlikely somebody's going to be able to consistently be sleepy enough to initiate sleep until 16 hours after the latest time they get out of bed in any given week. So, as an example, it's very common for folks to sleep in on the weekend trying to catch up. For a nighttime or an evening chronotype, that's just shooting them in the foot because they might catch up on sleep over the weekend, but then the delay that contributes in their circadian rhythm means they're going to give back any sleep they gain Monday, Tuesday, and Wednesday. And so again, those with that evening chronotype are more likely to struggle with getting to sleep at night. Interestingly, folks who are more morning folks, their sleep clock tends to defer to the earliest time out of bed in any given week. And so what does that mean? Again, It's common for morning folks to have more trouble maintaining sleep or a tendency to wake earlier than they want versus struggling to get to sleep to begin with.
That was a great explanation.
Yeah, and that's true for me. What about dealing with this circadian rhythm when you're someone that either works night shift or you're someone, I know there are some factories in town where somebody does a midday to evening shift several times, and then they do a night shift, and then they switch to a morning shift, and they're switching constantly. What do those people do to best protect their rhythm?
Yeah,
Because we know it's unhealthy.
Yeah, we know it's
right.
unhealthy.
There's plenty of evidence, but it's still their job.
And so again, this can be incredibly complicated, and that is very individualistic, because what we're trying to do for these folks is we're trying to see, okay, what can we get away with? How can we take this understanding of these 4 systems and optimize an approach to get this person's sleep as good as possible? These rules, they are malleable within reason, right? It's how far can we take it in order to optimize that person's sleep, understanding that our biology is not designed to do that. It's really biologically impossible to do this. So really, we're just trying to make the best of a less than optimal situation.
Yeah, and it's hard. It really is. Now, as we're talking about circadian rhythm, I think this is where a lot of information comes out about light exposure at night before bed. And I know I've seen in practice or sometimes even personally, we're trying to avoid lights, but many people notice difference even between a TV versus a phone, as well as just depending on their day, how much it impacts them. So it kind of gives them confusing feedback on whether or not it helps them to fall asleep or not by avoiding blue light before bed. Can you just explain how there can be such variation of that exposure for some people and how some may have zero impact and some do?
Yeah, absolutely. We like simple in healthcare, right?
We love that blanket answer.
Right? We want that blanket answer,
absolutely.
right? Yeah, it would be simple to say everybody should avoid all devices, all light whatsoever. And, I don't think that's necessarily the case for all people. And to speak to that, there is individual variability in terms of how impactful light in the evening is going to be for one person versus another. And just to speak to this, there is some interesting research done by Professor Gradisar. He was an Australian sleep psychologist. He was looking at teenagers. I have teenagers in my home. And again, he was trying to ask this question, right? How consequential is the cell phone at night? Interestingly, what he found is the amount of circadian influence based on this maybe not as consequential for all as we might think. And really what I would say is that signal of blue light at night is going to be more impactful if people aren't getting enough sunlight during the day. Arguably, if somebody's getting a lot of sunlight during the day, the amount of consequence of light at night may be a null factor.
That makes a lot of sense.
It does.
It does.
Yeah.
But I don't know. We don't tell people that.
I know, because it's too complicated, and complication takes time, right? It takes time to explain these things.
And it makes me even think personally, I feel like I see a bigger impact in the winter when it's dreary and whatnot versus summer now and getting so much more bright light during the day, of noticing that difference just on my own personal level. And so saying it that way, I'm like, oh, I think I've seen this.
Yeah.
Specifically.
Me too. So I guess really just view yourself as an experiment and maybe just really pay attention. Some days where you're stuck inside all day, see how it impacts you. And on days you're outside more, maybe just pay attention to that and gauge your personal sensitivity to blue light at night and decide if you want to turn it off.
Number 2 on the circadian rhythm inputs was physical activity. I feel like this one is left out of most sleep hygiene advice. How does that impact your circadian rhythm?
Yeah, physical activity is so important for us to be talking about, because if we refer back to those 4 systems that are involved in the regulation of our sleep, arguably 3 of them are impacted By physical activity. Sleep drive, obviously, the more physically active you are during the day, chances are the sleepier you're going to be at night. In addition, that activity during the day helps entrain the circadian rhythm. We also know that physical activity is probably one of the best stress management strategies out there. So yes, physical activity can be helpful for sleep because it impacts 3 of the 4 systems that are operating.
One of the other ones you mentioned that actually surprised me because I'd heard some of these, but I had not heard this specifically mentioned, which was socialization and that impact on sleep.
Yeah, socializing is hard to do. Physical activity is hard to do. And again, I think we're in a society that wants things to be easy, right? But I think we need to also understand that sleep is earned. It is not given. So the more challenge we put ourselves under, the more strain of sorts that we put the body under, probably the better it's going to work. It's just part of wearing us out. So I guess my encouragement is, do the difficult thing, right? Have that difficult conversation. Get out there and challenge yourself. And the more we establish a mindset of, I'm going to do the hard thing. I'm going to do that thing. Even when I'm tired, I'm going to get after it. And if we can find a way to establish that as our general philosophy to life, I think we're going to be better off.
I feel motivated already.
I love it. And the last bucket you mentioned was mealtime. This is something I know Kitty and I both learned more about by doing lifestyle medicine and the impact of that. How does mealtime play into this and our ability to sleep, and why?
Well, that's a great question. But we know what happens to people whenever they eat right before bed. Why might people wake up with reflux?
Exactly.
If they eat, we're probably not supposed to be eating there. So we're supposed to be eating during the circadian day. Interestingly, there's this line of research that's coming out that as a health psychologist I'm very interested in, and that is that I would argue that there's evidence to suggest that conditions like irritable bowel syndrome might be contributed to by circadian disruption, somebody that has a sleep clock that is out of whack.
Oh, that's fascinating.
It is.
Okay, and why might this be, right? Again, this was designed to protect our sleep. There's certain things that aren't supposed to happen at night. Again, not to be gross, but how often does somebody wake up in the middle of the night to go number 2?
Yeah, that's a red flag for doctors.
Right.
Oh, yeah.
Right. And again, as a sleep person, that would immediately lead to me going, the circadian rhythm is out of whack because it shouldn't be happening then. Eating when the body is actually actively involved in the digestive process is important. And again, there are so many conditions that we're identifying there to be the circadian element to it. I've had a number of teenagers that I've treated for delayed sleep phase syndrome who have migraine headache, for instance, and whenever we address their circadian rhythm, their headaches go away.
We talked about that last week because so many of my patients who dealt with challenging migraines to manage, I would say over half also dealt with sleep issues.
Yeah, and it's a double whammy.
Yeah.
You have a delayed circadian rhythm, that goes unidentified, untreated. That will ultimately develop into insomnia. And then you have the increase of cortisol from not getting enough sleep. You have the circadian disruption. Yeah, it's a recipe for migraine.
What do you think about sleep trackers? I was definitely behind the ball on figuring this stuff out. And I had a lot of patients coming in saying, I've got X, Y, or Z tracking my sleep, and it says I'm not getting restful sleep enough. And I always thought, do you feel okay? Can we just go by that? But I know Sarah has her Oura ring.
It's been interesting. I don't live my life by it, but I at least have learned some things from it. I would love to hear your take on it because maybe I can be persuaded the other way, but I have enjoyed having one just for some reflections when things are going on in my life, seeing the impact it was having on my sleep.
There's pros and cons to all things. And so let me maybe speak a little bit about potential pros and cons of all of these sleep trackers and wearables. The pro gets back to what you're saying, and that is it's a great opportunity for learning. So, for instance, if somebody wants to determine how late can I consume caffeine, and this not have a deleterious effect on my sleep, then putting on that sleep tracker, let's do it like an experiment. Let's keep the caffeine consumption the same and look at the data, and then let's change it, and then let's look at the data again, and then let's go back to it and do a real time series sort of design looking at. So I think that it's an incredible tool that can be used to help people identify what helps them and what doesn't. Now, on the flip side, we've actually had to create a new diagnosis called orthosomnia as a result of these, meaning that quite often people can develop an unhealthy obsession with tracking their sleep data.
Yeah, and I don't think it's just sleep data. I think we see this with people tracking their heart rate. There's so many things that can be tracked on this that I know I talk about this with patients. It's like you have to know thyself. Sometimes too much data is harmful for some individuals.
Absolutely. So again, you got somebody who's maybe a little higher on that sympathetic response, a little more easily activated. Now you get them getting all anxious about, oh no, what's my sleep data setting? And there's, again, we can talk about placebo effects. We can talk about the power of the mind. If somebody wakes up and their sleep tracker says they slept terrible, chances are they're going to feel terrible.
That's true.
Yeah. I wonder if there's ever been a study where they gave people wrong information and just told them that they slept well.
Actually has been.
Yeah, I bet that.
And yes.
And it was helpful.
It bears true.
Yeah. Speaking of things that can disrupt people's sleep and how they feel about it, can we start talking a little bit about people that have difficulty sleeping? What is the broad definition of insomnia, and what kind of different people fall into that bucket?
Yeah, so whenever we talk about insomnia disorder, this is defined as any time getting to sleep longer than 30 minutes or any time up in the night longer than 30 minutes, with that difficulty initiating and or reinitiating sleep occurring 3 or more nights a week and persisting for at least a month, with some consequence on their ability to be their best during the day. Now, conceptually speaking, again, referring back to those 4 systems, what I would contend is we call it insomnia when the learning system has gotten involved. And so if there's one question that somebody could ask to help with the differential diagnosis, is this insomnia disorder or is this something else, it would be this one question. Tell me if you've ever had this experience before, where you're out in your living room, watching some TV, doing some reading, whatever you do to wind down after your day. There while you're on the couch, you might notice yourself getting sleepy. Who knows, you might even doze off momentarily while you're there. So you catch yourself and you'll be like, okay, I think it's time for me to go to bed. So you get up, you brush your teeth, you get yourself all settled for bed. But then it would seem like as soon as you lay your head down on that pillow, awake.
We've heard that how many times in the
Oh my
office?
gosh, so many times.
So what is that? Again, in the field, we call that conditioned wakefulness or conditioned arousal. Human beings, we are all designed to learn from experience. So we learn what to expect will happen in particular situations by what has happened in similar situations in our past. And repeated experience of a particular type in particular situations ultimately programs the body to respond in specific ways. And this is all for the purpose of keeping us safe. So let's say, for instance, heaven forbid, somebody goes into a neighborhood and gets mugged. From that point forth, then, every time they walk into a neighborhood that in any way reminds them of that neighborhood in which they were mugged, what the body's going to do instinctively to try to protect them is activate the fight-flight response, dumping adrenaline into the bloodstream, making them hyper-aware of everything going on around them, so they're vigilant enough to pick up on the potential threat, and hopefully then don't get mugged again. Let's apply that same logic to sleeping. So let's say, for an extended period of time, instead of somebody going into their bedroom and falling asleep quickly, they were more likely to experience the stress, frustration, irritation, and anger at not being able to get to sleep. Waking up, can't get back to sleep. Over time, then, the body is going to perceive that whole process of going to bed in much the same way it would walking into a neighborhood in which they've been repeatedly mugged. So just going towards the bed activates that fight-flight response, which dumps adrenaline into the bloodstream, which neutralizes that sleepiness they were just experiencing on the couch. And there they are lying wide awake again. It is this insomnia disorder for which cognitive behavioral treatment is the first-line treatment.
I experienced this exact thing and saw the result of what CBT did because, as some of our listeners know, having a house fire that occurred while I was sleeping, initially for the first few weeks after that, that was the feeling that happened every time I hit the bed. But being able to work with a psychologist and working through that, I was able to get my sleep back. But I felt very fortunate because I knew what was going to come if I did not get on top of this, because of just understanding insomnia. I had dealt with it some in my past, that it quickly gets out of control. So I think that for some reason in our society, we will allow insomnia to last 3, 6 months, years before we actually try to seek help. When we start actually experiencing it, trying to address it sooner than later can help the reversal be quicker. Is that what you in practice? Because this situation, I was able to reverse quickly because I immediately got help because I knew I was setting myself up for exactly what you had mentioned.
Because the longer it persists, the more reinforced it becomes. What if we think about sleep meds? What do they really do? And is in the long term that really a good thing? So let me bring up another interesting concept that I think is related to all of this. And I don't know if y'all are familiar with the concept of fear avoidance. So let me explain it. Humans by nature, we are fearful creatures. And what do I mean by fear? I don't necessarily specifically mean fear. I mean, we're uncomfortable. We're uncomfortable critters. Okay, we're prone to discomfort. And interestingly, we are simultaneously incredibly motivated to do everything we can to avoid the inevitable discomforts of living. And here's the issue, and that is the more we avoid those things that make us uncomfortable, the more uncomfortable we get. And the more uncomfortable we get, the more motivated we become to avoid. And again, this really explains to some degree why folks who have taken sleep medication a long time, which I would argue is an avoidance strategy, why it is so terrifying for them to even consider life without it. And I would argue this is inevitable, that if every night we go to bed, we take this in order to sleep, right? One, we're not contending with that discomfort. And below the surface, the discomfort grows. And it becomes more and more contingent on engaging in this behavior. I think back to the Ambien days. This was marketed as the non-habit forming sleep drug. And you still see this on commercials. Oh, the non-habit forming. That's malarkey. From a learning standpoint.
And in practice.
Right? From a learning standpoint, these are pacifiers for fear. And the more we avoid, the more we fear, the more we fear, the more we avoid. And this gets people into a really rough spot.
And I think for our listeners, what is the, not only having to take the medicine on a daily basis, that's one part of it, but what is the negative aspect of using these sleep aids chronically?
Most sleep medications are bad for sleep. There are all kinds of risks that people incur by taking this path. Increased risk for dementia, increased risk for falls, increased risk for depression. There's a host of consequences of taking these, and obviously, depending on the type of medication, determines the specific risks that one might incur. But this is why these are not recommended as the first-line treatment. I would argue they're not a treatment at all.
Yeah. And many times, they truly are only supposed to be short-term use, but that is not what ends up occurring in practice.
Correct.
Yeah, because
Correct.
someone that has been struggling with sleep and then they take that for a short time and they're actually sleeping and then they're terrified to not take it.
It's building the fear and it's destroying their confidence, because ultimately what's going to happen is they're going to lose total faith that they can sleep on their own.
I have been taking magnesium for the last several months at least. And I think I was having a little harder time falling asleep. In general, sleep's not a big problem for me, luckily. But I started taking magnesium, and I don't know if it's the placebo effect or if it truly helped me sleep. But I'm continuing to take it at night, and I do feel like if I do forget it and I get in bed and I'm like, oh, crap, I didn't take that magnesium tonight. Then I'm like a little weird. Am I going to fall asleep? Am I going to be able to sleep as well? And so then you're like, yeah, is that a problem? And I know so many people take Benadryl or melatonin or valerian root or any of those. Are there harm to any of those over-the-counter options?
The antihistamines have been associated with increased risk of dementia. As far as what are the potential consequences of magnesium or melatonin, it's in an interesting category. Can this be helpful? Sure. And are there potential additional benefits to this? It's a pretty good antioxidant. But my main concern is just know that if you're relying on something outside of yourself, really that's going to chip away at that belief that you have in yourself. And I think that's inevitable. This is why when people come to see me, by the time they finally get to me, which often takes decades, unfortunately, even though this is the first line treatment, we all know it's rarely the first thing.
Oh, absolutely. Yeah,
Never.
it's hard to find someone who specializes in this. Yeah.
You know, by the time people get to me, they've got a sound machine, they got an eye mask, they're taking melatonin and valerian, they're taking magnesium, they've tried every prescription medication under the sun, and they come in and they're so defeated, right? They're so defeated and they feel like they're broken. They're like, these things should work. Everyone says they work. But that's just a terrible position to be in. And again, back to the placebo. It's fascinating. So whenever I was working in the Sleep Disorder Center, I also served as a consultant for our sister company there called Kentucky Research Group, who was involved in doing clinical trials on sleep drugs. And what I found so fascinating, and meta-analyses have demonstrated this, is I don't know if people are aware that over 60% of the benefit people get from taking any form of sleep medication is placebo. It's, I believe it'll help, therefore it does. And then that gets reinforced. Again, over 60, I think it's 63 point something
That
percent.
is high.
Yeah.
Yeah. You know,
That is a high result for a placebo. Yeah.
Here, let's get a little controversial
Yeah.
maybe. But after kind of having this reality hit me right in the face when I was doing this work, I was like, wow, how much of that is the case with other medications we prescribe regularly? Oh my. I don't know if you want to go down that rabbit hole, but the reality is so many medications we rely so heavily upon in this healthcare system are really only marginally better than sugar pills.
Yeah, I believe in the power of the mind.
And we spend billions of dollars in our healthcare system on this stuff.
So let me give you an example patient, and I want to see what you would recommend for them. So let's say there's somebody who typically does not have trouble sleeping, but maybe they've had a little more stress than usual lately. Maybe their kids aren't sleeping as well lately, and they have a couple nights in a row where they haven't slept well. They're not feeling good in the day because of that. And now they're like, oh man, I got to do something. I got to get some sleep. I don't want this to become a pattern. And most of the time that person will go maybe try to take Benadryl for a night or two or something. Instead of doing that, because we understand now that's not a good path to go down and you're amplifying that fear, what should a person that's just experienced a short time of insomnia do to try to keep that from becoming long-lasting?
It's easy to say, but I'd say don't fret. And I would say walk into it.
I'm sensing the resistance from the patient.
Yeah, I know. This is the hard thing that we humans, right? Remember, we're fearful creatures and we want to avoid those things that are uncomfortable. But there is such a thing as functional insomnia. What do I mean by that? Sometimes we can't get to sleep. Sometimes we wake in the night and can't get back to sleep because this is our mind desperately trying to bring our attention to something that warrants our attention. And the more we resist giving it the attention that it's asking for, the more it's going to come back. So what would I say? You got some stressor in your life. It's that stress is telling you, you need to do something about this. Stay up and do it. Stay up and figure it out. Don't sweat in the short term not getting enough sleep. The reality is no matter how good of a sleeper somebody is, nobody sleeps well every night of their life. Life happens. And so I would encourage these folks to take the challenge, to stay up. Okay, what do I need to figure out here? And if I need to be up till 2 a.m. to figure it out, so be it. But then still get up at your normal time and go forth. So the more we fight against that fear, the better off we're going to be. And here, let's give another example. So let's say somebody has a fear of flying. What do they need to do to overcome that fear?
Fly.
Yeah.
Sorry.
Yeah, they need to fly. But hold on, let me throw this in there. So let's just say that you have a friend, good friend, and they have this fear of flying, and you really would like to travel more with them. And you get sick and tired of this fear preventing you from doing the traveling you want to do. And so you go to Google Doctor and you find out that, yeah, you need to fly. That's the answer, right? And so you take it upon yourself. You pack all their stuff. You go pick them up at their office. You get them to the airport. You drag them against their will onto this plane, force them to take that flight. Is that going to help their fear?
I'm going to go not unless they want to take.
Yes, if they are subjected to this against their will, the desensitization won't happen. The person has to willingly take on that discomfort in order for that to have the desired outcome. So again, a lot of this is working with folks, helping them understand what's going on, and facilitating the process of them developing the will to do that challenging, difficult thing, which is a process, and it takes time. And it certainly will never happen in a 7-minute office visit.
No, it won't. No, it won't. Oh, something that I experienced years ago, and understanding this, you had mentioned just stay up that night and get whatever you need done. But in today's world, for many people who are working, sometimes just because of the hours in the day, you end up working, say you have kids, you have to finish work before bed. And that can be very challenging if it ends up being day after day, right? If there's a project deadline, staying up that one night, getting it done so you mentally the next night can sleep. But when you have a profession that is a continued stressor like that, which I know Kenny and I have experienced in primary care, how can you try to address that so it doesn't turn into a chronic insomnia when it is a stressor that is so continuous?
Yeah, it's a stressor you can't eliminate. It's
Right.
something that ultimately you need to figure out how to mitigate. And so I think then it's important to be proactive. I think too often, and this may not surprise you, but I see a number of physicians.
Not
at all.
surprised, in a profession that literally promotes lack of sleep as part of the job.
And again, I think it starts with having a discussion about, do you really understand how stressful what you do is? How difficult, again, you're having 15, 20, who knows how many interactions. And social interaction isn't necessarily easy. It's stressful. It's challenging. Sure, maybe there's one day out of an entire career where you go in and everybody is doing exactly what you'd ask them to do and everything goes easy, right? Maybe, but I would suspect that's generally not the case. And so it's acknowledging, yes, what I do is stressful. And so I need to take it upon myself to do everything I can during the day to prevent the accumulation of dumping of stress hormones into your body. So quite commonly, obviously when we intervene, we teach people, hey, this is how the human anxiety response system works. This is why it works that way. And here's some things you can do during the day to help keep that response at bay. Things like breathing. But it has to be practical. You're not going to go lay down and do a 30-minute meditation at work.
Right.
That's not practical. But it can be simple things like, hey, once an hour I want you to stop and I want you to acknowledge, I want you to slow down your breathing just for a minute or two and say something reassuring to yourself. Something like, I got this. I know this is hard, but you know what? I got it. Just to bring it down. And because again, we're trying to prevent so much of this accumulating. So there's not this pressure to try to get it all out of your system in the last hour of the day. So we got to be proactive.
I think that is such great advice.
It's really great advice. Yeah, we need the list of all the things we can be doing throughout the day.
But hold on,
that makes
remember, we're
perfect
not
sense.
doing lists because everybody's different.
Then you're worried about,
Everybody's
did I get all of
different.
those things done
Right?
to
Yeah,
mitigate my
everybody's
stress?
different.
Yeah.
It's very individualized.
And I hate this because while it's nice to have access to so much information at your fingertips, I think that also is some of the problem with this because you can search, you can find a checklist, you can do all those things and you're like, it didn't work for me, I have no hope. I think that has been such a downside in medicine now is because of there's being so much information of people trying to translate everything to them specifically, but no one's taking in all the information about their own unique circumstances and what they should expect.
Yeah, it's information overload, and there's far too much out there. And again, there has to be a depth of understanding, whatever that is, in order for it to really have any positive impact.
And so for someone that is having trouble with insomnia and they realize they need to do something about it and they wanted to see someone and look into cognitive behavioral therapy, how does someone even go about finding someone that is appropriate? What would that look like? Does insurance pay for it? How long would it take for someone to see improvement? What would you counsel someone that the whole process would be like?
Yeah, fortunately, we got more and more resources available. There's apps available that people can try. Obviously, there's an increasing list of folks who are trained to do this sort of work. I would encourage folks to first go to the organizations that are boarding people in this practice. So it would be wise to, if you're looking for somebody in your area that does this sort of work, the Board of Behavioral Sleep Medicine is a place they could go. They could go to the American Board of Sleep Medicine and look for those who are certified in the practice of behavioral sleep medicine. They could go to the Society of Behavioral Sleep Medicine. There are lists of providers there where they could try to find somebody. We have been passionately doing all we can to try to get the word out about these strategies. But I know it's a tough sell. Sometimes I feel like we're selling hot coals to snowmen. Because it's the hard thing. It's the hard thing. It's not the easy fix. It's understanding, and quite often it takes people being tried on multiple medications and developing tolerance and ultimately realizing that they're ending up right in the same place that they were before they start to acknowledge, okay, this isn't the right path. But we're trying desperately to increase access, and I do believe we've done a great job of that over the last 20 years, whether that be with apps or increasing number of providers. Every year there are more folks who are getting certified in this area of practice. But I understand that it's just not where any of us, I think, would necessarily want it to be at this point. I think at this point, the obstacles are many. There's stigma that we're still dealing with in terms of reaching out for help. People just are uncomfortable asking for help. And I think too often people are going to Chat GPT, or they're going to Google, or they're desperately trying to find their own path. And I understand that, but the reality is understanding. I've been studying and working in this area for over 20 years, and I still don't know everything. It's why go to somebody, right? Why pay somebody for this? Because they're saving you time. They've already done the research. They can help figure out very quickly, this is what you specifically need to do. And they can do it quickly. CBT for insomnia is not forever therapy. And honestly, I wouldn't call it therapy. I prefer to call it treatment. So I would call this cognitive behavioral treatment because it has the greatest chance of actually fixing this problem. The outcome study that we published back in 2009 suggested we put into remission over 50% of those we saw. And these are folks with insomnia for decades.
That's impressive.
Okay.
That is
and
so
we got
impressive.
almost 80% of people off sleep drugs. And again, that was when I was working in the widget factory. Okay? I would argue that if we redid that study now, our outcomes would be far better than even that. And if we think about, okay, 50% chance of remission, that's really in medicine a pretty impressive outcome.
Yeah, within the downstream effect of fixing insomnia. It's not just that. It's because insomnia and poor sleep bleeds into so many chronic conditions that you're actually improving your health on multiple levels by doing that.
Yes. I'm glad you mentioned downstream. I don't know. I got a little soapbox on this.
Okay.
I don't know if you're interested in
Let's
sharing
let's
it,
go.
right? Okay. But here is one of my greatest concerns about what's happening in our healthcare system is I do feel like we are far too often intervening downstream, meaning we're not taking the time to paddle that canoe up that mountain to figure out what is the actual cause. And I think what's happening then is we're sometimes confusing cause and effect. And to give you some examples, testing cortisol, for instance. So your cortisol is high, that's why you're not sleeping. Hold on a second, right? Lack of sleep increases cortisol. Lack of sleep reduces testosterone. Not enough sunlight leads to not enough melatonin. So again, it's like we're looking down here and we're going, the answer is testosterone replacement, or the answer is cortisol manager, and I would argue that this is we're addressing the consequence, not the cause. And how often is that happening in our healthcare system?
It's not. And that's why Kitty and I are so passionate about lifestyle medicine, because so much of what we see is actually related to the basics. And unless we pay attention to these basic pillars, we're always working downstream.
Yeah, we're always chasing things instead of being proactive and getting out in front. So, yeah, that's a great reflection. And I think just from seeing a lot of patients over the years with trouble sleeping, this downstream effect a lot of times happens because people don't want to address the upstream effect. They don't, let's say, the cortisol example, their cortisol is higher. They're stressed. They're worried. There's something maybe stressful in their relationship in their life, and dealing with that seems harder than just taking a pill for sleep. And
yeah, it is harder, right? It is harder. And again, it gets back to that fear avoidance. I think I think there's many reasons why people may not get to CBT-I. And it's really quite complicated, and it's individualistic as well. There's time constraints, there's money constraints, there's all kinds of different reasons. We also live in a quick fix society where we want it now, right? Amazon can deliver you that book the next day. We expect that to happen. But I think there needs to be this understanding that when it comes to sleeping, there really is no quick fix. And what's going to happen is folks will jump from quick fix to quick fix and ultimately end up right back in the exact same spot. So I think that there's room for doing all we can to encourage folks to do the hard thing. And sometimes that might mean that people struggle a little bit, but it's what are we doing here? Do we really want this person to be well? And what can we do to motivate them to do this? I really think this is one of the opportunities that there is in primary care is there's a trusting relationship. It's telling stories like you did about your friend and helping them know that, no, this isn't going to take forever. People start responding to CBT-I in the first 2 weeks. It doesn't take as long, and it's not as high of a mountain to climb as many people believe. But it's a lot of the fear of the unknown. So we do need to do everything we can to destigmatize this sort of process. We need to meet people where they are, and we have to try to figure out how can we correct any misunderstandings they might have about what they're being asked to do. There's lots of misunderstandings. They're gonna think I have an anxiety disorder, or I'm gonna be in therapy for the rest of my life, and that's just not the case, because I can tell you that when people finally get to us, the most common thing I hear from folks is, why did I never hear about this? So we talk about fear or discomfort of patients. There's also fear within the provider. I'm afraid if I don't rescue you from your distress in this moment, you will think badly of me as a doctor, or you will go online and give me a terrible review, and then I'll get my pay cut because they're based on some performance metrics or what have you. And yeah, I think it's developing that confidence that can be conveyed, that can just ooze out of your pores when you make that recommendation. And yeah, it's going to be different for everybody, but yes, it's going to be difficult.
Yeah, I think that's very true, reflecting on the physician's ability to recommend. In our training, we learn a little bit about sleep hygiene, but really there's just so much to learn. You end up learning a lot from your patients over the years, and seeing some people that I know do better with CBT-I was how I started recommending it, but it wasn't actually something I learned through the medical system. It was just meeting and seeing people have success with it, and me realizing this is so much better than all of these medications that we learned about and knew the mechanism of action backwards and forwards and the risks and things, but we didn't truly learn about this other option.
Yeah, no, and this is so true that unfortunately, physicians and psychologists are trained in totally different, not interacting silos. And so I would say that probably the most effective referral sources that I have are physicians who trained with me, meaning these are folks who were, again, in a sleep medicine fellowship at U of L. They have they can come over and spend time with me, because you don't necessarily fully understand or know what's happening in that silo until you're there.
Yeah.
And with that level of understanding, the comfort and the confidence in making these referrals, and then obviously those who are being referred feel that and sense that, and that greatly improves the likelihood of them going, yeah, I'm going to do that. I'm going to do that difficult thing.
And so if you had someone that was considering doing CBT-I, let's say they're on a prescription sleep medication right now, and they are feeling a little resistant to doing this hard thing, and they say, I have a lot going on. I'm just super busy at work. It's tax season. They're an accountant. It's tax season. I'm very busy, and you're telling me you want me to go take away my sleep medicine.
Ooh.
And go through this behavioral therapy to be able to sleep. Like, that sounds like something I can't do.
Yeah, no. And let me just say this, and that is that I've treated brain surgeons when they're actively doing brain surgeries. They've gone through CBT-I, right? So I understand that it can be daunting, but I think people need to understand that nobody's going to take away their medication. We're not kicking crutches out from under people, right? No, it's a very systematic, seamless transition. So when we work with somebody who's taken, let's say, Ambien for decades, we can't just say, stop it. That's a terrible idea, right? So it's a process of systematically rebuilding that person's confidence in themselves while gradually reducing that medication, right? And again, it could be that, okay, yes, now is tax season. I'm super busy. I just don't have time to do it. Okay, when would be a good time? Let's get you on the schedule for your low season, and let's plan to do that, because that'll bring the amount of fear and anxiety down just enough where maybe there's a willingness to consider this. In the middle of tax season, maybe that's just not the right time to do it.
So it's not something you're going to have to stop your life for, but it's something that you want to be a time of your life where you're ready to give it the attention it needs.
It's never as difficult as people believe it will be, but they don't know that until they're in it, because the reality is that people sleep better during it, not worse. So again, it's that I'm afraid this will happen if I do this. Probably not.
I think this is probably a message so many people should hear. Even my response to someone, if trying to get them to do this, may have not been completely appropriate. And telling them, hey, by getting this started, you may sleep better sooner, not worse, once you start. And I think having that reassurance is huge when you've dealt with this chronically for a long time.
Yeah. I mean, you understand that they're terrified. They're probably coming into that visit afraid that you're going to take away their medication. They're going to be, again, they're scared.
I think you have definitely helped with that fear. I wanted to ask you one more thing before we get into how someone could come see you, because obviously you seem like you could help a lot of people out there. But when we throw some wrenches in our sleep for certain situations like vacation or traveling to a different time zone or kids having issues that are waking you up frequently with sleep, is there anything we can do proactively to try to help with that?
Yeah, and again, there's pros and cons, right? Because it's a slippery slope. Somebody could take something for a period of time of, let's say they're planning to go to Europe and there's gonna be jet lag, and there are strategies that we can introduce people to prepare their circadian rhythm for that transition. But I also think it's just very important for folks to give themselves the opportunity to have the experience of not getting enough sleep and being okay. Because if we know, hey, as long as I get 5 hours, I'll be fine, the pressure isn't going to be nearly as high. And sometimes I wonder, is it the lack of sleep that really contributes to consequence? Or is it the anxiety about the lack of sleep that's really the driving force behind the deficits that people are experiencing? And I think sometimes it's tough to tell which is which. And so again, it's be thankful for these challenges. Be thankful for these opportunities that life is certainly going to give us. That opportunity to not get enough sleep for whatever reason, and then learn, I got this.
That's a great reflection, because I do feel having kids and having many sleepless nights with children, unpredictable, never knowing what one night would be, actually taught me that I can still function and be okay. More so beforehand, when I would have a bad night's sleep, I worried about it a lot more because I didn't have that feedback knowing. There's been times where I've had a really bad week of sleep. When things settle and I get it back again, it's okay. That was a very good feedback to reflect on and help me in the long run in life. Because I'll even use that today. If I'm sick or something crazy happens, okay, that was a really bad night's sleep, not panicking that the whole day will be ruined and I have to worry about sleep already about tonight. It's just knowing that was bad. Can't wait to sleep tonight. I think that is such a good reflection, because I do think that made a big change in my own life doing that. I don't know how you feel about that, Kitty.
Yeah, and I think I've noticed if I don't sleep because maybe something's just been on my mind, or the reason I'm not sleeping is me, versus if I have a kid who's puking all night and I end up being up from 2 a.m. on because they're sick, I don't seem to fret about that as much. I know They're going to get over it. I am a little fearful that it's going to start in me at some point in the next 48 hours. But it's like, in reflecting now, I've never really thought about that before you just mentioning that. I worry much more about it when it's just me. I caused my sleep issue, and how is that going to manifest? So that's an interesting thought of us not being able to deal with the discomfort or the fear around it sometimes.
Yeah, this is, I think, society maybe is starting to realize this a little bit. And what I'm referring to is this concept of mindfulness. What is this really about? I mean, there's, again, obviously the meditation component and all of this, but I think there's a really valuable concept in that, the concept of radical acceptance, of being able to acknowledge and find peace with the fact that we really don't have control. And that's okay. It's okay. Let's find a way to be okay when we're not okay.
I love that quote.
I've written down several quotes from
I think my psychologist used that. That's why I know that one. It's okay to not be okay, Sarah. Yep, I've heard that one. So for our listeners, because we do have a lot of listeners in the state of Kentucky, how could someone reach out to be seen in your clinic, and what kind of options do you have to see patients?
Probably the best way to reach out you can always go to our website. That's sleephealthlou.com. They can always call as well, 502-822-1320. But again, check out the website, and we do telehealth visits where I am PsyPAC certified, so technically I can see people in, 40-something states now. Don't hesitate to reach out if folks have any questions. We're happy to answer these questions.
And how long does it usually take to get people in today?
I've decided to take some much-needed vacation, so right now it's a little longer than usual. But the beauty of this is we're generally able to get people in a couple of weeks.
That's great.
If they are ready to do it, we're ready to serve. And I have another associate who joined me, Dr. Abbott, and then we also have a pediatric provider, Dr. Kuhn, if, again, this is more concerns about how your kids are sleeping.
Well, that might need to be another episode someday. You have taught us so much. I'm going to try to do a little summary, and I'm going to throw in a few of the quotes that you had today that I thought were so good, starting with, sleep is earned, it is not given. And that's an interesting way to think about it, but I think that is a great way in thinking about those 4 things that you mentioned we need to be doing throughout the day in order to build up the correct signals in our body to help us actually sleep at night. And that's getting that sunlight, getting physical activity, socializing throughout the day, and timing your meals correctly. And so you need to get that in order to have earned that sleep at night and make it easy to fall asleep. You also need to be consistent with your wake time, and that might be natural for you depending on your chronotype. And if you are someone that's a night owl and you're staying up late on the weekends, you're probably going to be paying for it Monday, Tuesday, Wednesday of the following week. So just make sure you're paying attention to that. And when it comes to looking at the impact of blue light, really just pay attention to yourself. Notice how much does it affect you, because you may be someone where it's very impactful and you may be someone where it's not. And then pay attention to how much natural sunlight you're getting throughout the day, because getting more of that may help you to be able to have more exposure to the blue light at night. Sleep trackers, Sarah, I'm going to tell you, I do not want you to develop orthosomnia. And make sure you're using those sleep trackers really as an opportunity to learn about yourself, and don't use them as a judgment of yourself and your sleep quality. If you are dealing with insomnia, try to just not fret and see if you can just find a way to be okay when we are not okay, and try to experience not getting enough sleep and understand that you will still be all right. instead of just jumping into medications and treatments, because as you've informed us now, we know that 60% of the benefit anyway is just due to the placebo effect of taking that pill at night. If you're new into having trouble sleeping, try not to jump on that bandwagon. See if you can go ahead and look into some cognitive behavioral treatment instead of going down these other routes. If you've already been down these other routes and you've been on medications forever, you are not a lost cause. And cognitive behavioral treatment, I'm sticking with that instead of therapy, is a great option for you. Realize that it's not forever. It is not as difficult as most people think it is. And usually you're sleeping better as you go through this. So hopefully, if you're someone that struggled with sleep, we hope that this episode has been hopeful for you, that there is an answer, and we hope that you share this with anyone you know that may be struggling with sleep.
Next week, we will continue our sleep series, and we have Dr. Lauren Whitehurst from the University of Kentucky, who is a researcher there, and she's going to talk about the stages of sleep, what's happening in our brains as we sleep, and how to maximize our learning and memory, and how to use naps in our lives. We hope that you're all enjoying this series. I know we were really excited to bring all this information to you all, but if there's any other topics that interest you that we haven't done yet, please send us a text, send us an email at contact@thestartinggatepodcast.com. We'd love to hear from you and hope you all have a great week.
See you next time.